or, someone takes a pill for high blood pressure, there's a very good chance you assume the doctor just picked it off a standard list.
Right, like it's just a generic choice.
Yeah, exactly. Like you have a headache, you take ibuprofen. You have high blood pressure, you take a blood pressure pill. It feels like this really simple, straightforward transaction.
But the reality of treating the so-called silent killer is vastly different. It's actually this deeply strategic, highly customized game of biological chess that's happening behind the scenes of every prescription.
It really is. And welcome to a brand new deep dive, by the way. Today, we are decoding that modern strategy. We've got a fascinating set of source materials in front of us.
We do. Specifically, this masterclass set of lecture notes from Dr. Asifullah at Khyber Medical University.
And he takes these latest, incredibly dense guidelines from the American College of Cardiology, the American Heart Association, and the European Society of Cardiology. And, he basically distills them into a playbook.
Which is so needed because those guidelines are thick.
Well, absolutely. So our goal today is to show you the precise, almost puzzle-like strategy doctors use to choose the absolute perfect combination of medications tailored specifically to the patient sitting in front of them.
Because it is the absolute definition of precision medicine. We're looking at a medical landscape that has evolved way, way beyond trial and error guessing.
Right. It's entirely evidence-based now. But, before we get into those complex treatment pathways, we kind of have to look at the tools that are actually available in the doctor's toolbox.
We have to know the pieces on the board.
Exactly. So Dr. Asifullah uses this really helpful mnemonic to categorize the big four weapons against hypertension. And it's just ABCD.
Easy to remember.
Super easy. That stands for ACE inhibitors, or ARBs, beta blockers, calcium channel blockers, and diuretics. And I think the best way to conceptualize how these four distinct classes work is to look at the cardiovascular system, kind of like the plumbing in your house.
That's a great analogy, yeah.
Right. So if the water pressure in your house is dangerously high, the pipes are rattling, you're at risk of a burst, you essentially have three mechanical ways to fix the problem.
Which perfectly mirrors the physiological approaches we actually take with medication.
Yeah, so first you could just go down and turn down the main water valve at the source.
Right.
To reduce the sheer force pushing through the entire system.
And that is essentially what the A in our mnemonic does.
The ACE inhibitors and the ARBs. Drugs like lisinopril or losartan.
Exactly. They target a physiological chain reaction called the RAAS system.
Wait, RAS, that's a renin-angiotensin?
Renin-angiotensin-aldosterone system. Yeah, it's basically a hormonal cascade. So when your kidneys think your blood pressure is too low, they release an enzyme called renin.
Oh, okay.
And that eventually produces a highly potent chemical called angiotensin II. And angiotensin II aggressively tightens your blood vessels.
So it's actively squeezing the pipes.
Right. So ACE inhibitors block the enzyme that creates that constricting chemical. By stopping that tightening, they lower what cardiologists call afterload.
Afterload, that's like the resistance the heart has to pump against, right?
You got it. They basically turn down that main valve, taking the workload off the heart while also, and this is key, providing incredible long-term protection for the fragile filters inside the kidneys.
Oh, wow, okay, so that's the main valve. But if tuning down the valve isn't the route you want to take, your second option is to physically just, swap out your narrow pipes for wider pipes.
Yeah.
Wider pipe, lower pressure.
Makes sense mechanically.
Yeah, and that brings us to the C in our mnemonic, the calcium channel blockers, or CCBs, like I'm
Well, and this is where we see the concept of arterial vasodilation. So calcium is this crucial element that tells the smooth muscle cells lining your arteries to contract, to squeeze tight.
Right.
Well, these medications block calcium from entering those muscle cells. So without the calcium, the muscles literally cannot maintain their grip.
Oh, wow. So they just give up.
Exactly. They relax, the arteries widen, and the pressure instantly drops.
Okay, which leaves us with the third plumbing fix. You just bail some water out of the system entirely. Like, less total volume of water inside the pipes means less physical pressure pushing against the walls.
Right. Less fluid, less pressure.
And that is the D-diuretics, specifically thiazide diuretics, like clothalidone. They act directly on the kidneys, right?
Wow, they force the kidneys to excrete more sodium into your urine. And because water naturally follows sodium out of the body, you're actively reducing the plasma volume in the bloodstream.
So to recap, you lower the central force, you widen the pipes, or you decrease the fluid volume.
Those are the three primary pillars of everyday blood pressure control.
Wait. I'm confused here. I'm looking at Dr. Asifullah's ABCD mnemonic. And we just covered A, C, and D as the primary pillars, but the B stands for beta blockers.
Right. Drugs like metoprolol.
Yeah, but looking at these ACC and ESC guidelines, they practically beg doctors not to use beta blockers for standard, uncomplicated high blood pressure. They say that they just don't have the same stroke-reducing benefits for the average person.
It's a great catch.
So why are they taking up a whole letter in the core acronym if we aren't even supposed to use them?
I know, it seems like a glaring contradiction. If a patient walks in with isolated, everyday high blood pressure, A beta blocker is just not the correct choice.
Okay.
However, beta blockers are a specialized, incredibly potent tool that immediately jumps to the absolute front of the line if the patient has what we call a compelling indication.
A compelling indication,
Yeah.
meaning like a pre-existing condition that completely rewrites the rules.
Exactly. Think of a beta blocker as a heavy-duty governor on an engine. It blocks adrenaline from binding to the heart receptors.
Oh, so it physically slows things down?
Right. It slows the heart rate down and physically reduces how forcefully the heart muscle squeezes.
Why would you want the heart to squeeze less forcefully?
Well, say you have normal blood pressure, but you just suffered a heart attack. A post-MI, post-myocardial infarction, part of your heart muscle has actually died.
Right.
So the surrounding tissue is highly vulnerable, and it's overworking to compensate for the dead tissue. It desperately needs rest. A beta blocker forces that damaged engine to slow down and heal.
Ah, okay. So it's actively shielding the heart from its own adrenaline. That makes total sense.
Exactly the same principle applies if a patient has HFrEF.
Heart failure with reduced ejection fraction.
You got it.
Okay.
Which means the heart is too weak to pump effectively.
Right.
Or, if they have a dangerous electrical arrhythmia like atrial fibrillation where the top chambers of the heart are just quivering way too fast.
So in those high-stakes, really specific scenarios, beta blockers are literal lifesavers.
Exactly. They just aren't the everyday wrench for your standard plumbing issues.
Got it. Okay, so now that we have the tools laid out, the real question is how doctors actually deploy them. Because from what I'm reading, the old school method of handing a patient one pill and telling them, come back in a month, that's completely obsolete.
Oh, entirely. The landscape completely shifted, particularly with the European Society of Cardiology's 2023 guidelines.
The ESC guidelines.
Yeah. They aggressively lowered the target blood pressure for most adults to below 130/80 millimeters of mercury, assuming the patient can physically tolerate it.
That is a remarkably strict target. I mean, 130/80.
Yeah.
So if someone comes into the clinic and their pressure is hovering at, let's say, 160/100.
Which is high.
Yeah, really high. So the intuitive move would be to grab one of those tools, say an ACE inhibitor, and just prescribe a massive maximum dose to force that number down, right?
Which is precisely what doctors used to do, and we now know it backfires terribly.
Really? Why?
Well, monotherapy relying on a single drug is often totally insufficient for these stricter targets. The human body is remarkably adaptable.
So it just fights back.
Right. If you crank up the dose of an ACE inhibitor to its absolute maximum, you hit receptor saturation.
Okay, so you max out the benefit.
Exactly. You don't get much additional blood pressure reduction, but you dramatically increase the toxic side effects of the medication, so you end up with diminishing returns and a really miserable patient.
Wow, okay, so the new strategy just avoids that entirely by utilizing what the notes call early combination therapy.
Yes.
Dr. Asifullah outlines this really fascinating stepwise approach. Like step one usually starts with dual therapy right out of the gate, ideally combined into a single pill just for convenience.
Patient compliance is huge.
Oh, for sure. So you take an ACE inhibitor or an ARB, and you pair it with either the C, a calcium channel blocker, or the D, a thiazide diuretic.
And by doing that, you're attacking the high pressure from two completely different physiological angles.
Which allows you to use lower, safer doses of both drugs.
Exactly. It creates a synergistic effect.
Yeah.
You're simultaneously turning down the hormonal water valve and actively widening the pipes.
That is so smart. Okay, and if that dual approach fails to hit that 130/80 target, you escalate to step two.
Which is triple therapy.
Right. An ACE or ARB combined with a calcium channel blocker combined with a thiazide diuretic. All three.
Yeah, the whole trio.
But looking at the mechanics of step one and step two, there is a massive, flashing red warning in the notes here.
Yes, the golden rule.
Right. You must never, under any circumstances, combine an ACE inhibitor with an ARB.
Mm-hmm.
And, on the surface, that seems kind of counterintuitive.
Yeah, so.
Well, they both start with A. They both target that RAAS hormonal cascade.
Right.
So if one is good, wouldn't blocking that system with two different drugs be, twice as effective?
The logic totally makes sense until you look at the biochemistry.
Okay.
Because both drugs target the exact same hormonal pathway. Combining them doesn't double the blood pressure drop. It actually yields zero additional cardiovascular benefit.
Really? None?
None. But what it does do is completely paralyze your kidney's ability to excrete potassium.
Oh, wow. So you're just wrecking the body's internal chemistry.
We call it hyperkalemia, dangerously high potassium levels in the blood. Potassium is the electrolyte responsible for conducting the electrical signals that tell your heart muscle to contract.
Okay, so if that gets messed up.
If those levels spike too high, it can literally cause fatal cardiac arrhythmias. It stops the heart.
Oh my God.
Yeah. Furthermore, combining an ACE and an ARB has been definitively proven to cause acute kidney injury, or AKI. You are actively destroying the patient's renal function for zero clinical gain.
So bottom line, never cross the A streams. Got it.
Never cross the streams.
So we combine safely across different classes, but deciding which specific combination to use is where this science truly becomes like an art form.
Absolutely.
This isn't just treating a number on a cuff. It's highly personalized medicine. The notes dive into how demographic quirks and existing medical conditions totally dictate the drug choice.
A pregnant patient is a perfect example of this. You just cannot deploy the standard tools. ACE inhibitors and ARBs are strictly contraindicated in pregnancy because they interfere with the fetal RAA system. They cause severe developmental abnormalities in the baby's kidneys and skull.
Oh, wow. So you have to completely pivot.
Right. Doctors must pivot to highly specific, safe alternatives like labetalol, methyl-dopa, or nifedipine to manage the mother's pressure without crossing the placental barrier in a harmful way.
Okay, but then on the flip side, if a patient has diabetes or chronic kidney disease, especially if they have like protein actively leaking into their urine,
Right.
ACE inhibitors or ARBs are an absolute non-negotiable requirement.
They are. And the mechanism there is so fascinating. Those drugs do lower systemic blood pressure, but they also have a highly localized effect inside the kidney itself.
Okay, how does that work?
Well, the kidney filters blood through millions of these microscopic tufts of capillaries called glomeruli. In diabetes, the pressure inside those tiny filters gets dangerously high, and that forces vital proteins out into the urine.
Like pushing them through a sieve that's under too much pressure.
Exactly. ACE inhibitors specifically dilate the exit vessel of that filter. It's like opening the drain on a bathtub.
Oh.
Yeah, the pressure inside the filter drops immediately, stopping the protein leak and protecting the kidney from long-term scarring.
That protective shield is incredible.
Yeah.
That makes so much sense. But then the strategy shifts entirely again when treating Black patients.
Yes, it does.
The data shows that the RAAS system, that hormonal cascade ACE inhibitors target, often behaves differently in Black populations. Many Black patients have what is known as a low renin profile.
Right. Because their bodies naturally retain salt more efficiently, their kidneys actually suppress the release of renin.
Okay.
So if there is very little renin circulating in the blood to begin with, giving a drug that blocks the renin-angiotensin pathway, it just isn't going to accomplish much. The target is simply too small.
Ah.
Therefore, the guidelines heavily emphasize calcium channel blockers and thiazide diuretics as the most effective starting tools for Black patients. It directly addresses the vascular tone and the salt retention.
Okay, and then there's the elderly, which also require a totally specialized approach.
Very much so.
Because as we age, our blood vessels lose their elasticity. They become, stiff and rigid. And this leads to a very specific condition called isolated systolic hypertension.
Right, where only the top number on the blood pressure reading is dangerously high, while the bottom number remains perfectly normal.
Because the pipes can no longer expand to absorb the shock of the heartbeat.
Exactly. So using calcium channel blockers to artificially force those stiff, smooth muscles to relax, or thiazides to lower the total fluid volume slamming into those rigid walls, provides the most effective relief for that demographic.
Navigating all these different patient profiles is complex enough, but then the lecture notes get into these bizarre, highly specific drug quirks and side effects that completely alter the game board.
Oh, the quirks are the best part.
They really are. Okay, so the most famous one is the ACE cough. The notes say between 5 and 20% of people who take an ACE inhibitor develop a persistent, dry, hacking cough.
Yeah, it's very common.
And most people assume it's just a mild allergic reaction. But the biochemistry tells a totally different story.
It has absolutely nothing to do with allergies.
Really?
Nope. So, ACE stands for angiotensin-converting enzyme. We know this enzyme's primary job is to create the protein that raises blood pressure. But it also has a secondary job.
Okay.
It acts as a cellular garbage disposal. It breaks down a different peptide called bradykinin.
Okay, so when you give a patient an ACE inhibitor, you stop the enzyme from raising their blood pressure.
But you also break the garbage disposal.
Oh.
Yeah. The enzyme can no longer break down bradykinin. So bradykinin begins to accumulate in the tissues, and it is highly irritating to the respiratory tract.
That's crazy.
That biochemical traffic jam in the lungs is the direct trigger for that dry, maddening cough.
So how do you fix it?
It's remarkably simple. You just switch the patient to an ARB. ARBs block the blood pressure receptors further down the chain, leaving the ACE enzyme fully functional to break down the bradykinin.
Okay, speaking of ARBs, this brings up my absolute favorite paradox in the entire set of notes. It revolves around gout.
Oh, yes. The gout paradox.
So we established earlier that thiazide diuretics are fantastic for bailing water out of the system. But when you reduce the water volume in the blood, you inadvertently concentrate other substances.
And one of those substances is uric acid.
Right, which is the exact mechanism behind gout. Uric acid crystallizes in the joints, typically like the big toe, causing just agonizing inflammation.
It's incredibly painful. So giving a thiazide diuretic to a patient with a history of gout is basically guaranteed to trigger a severe flare-up.
Which presents a massive clinical dilemma if that patient desperately needs their blood pressure lowered.
Exactly. What do you do?
Hiding inside the ARB class is a hero drug called losartan. Losartan lowers blood pressure just like the rest of its class, but it possesses a completely unique, almost magical secondary property.
It's the only ARB that has a uricosuric effect.
A uricosuric effect, meaning what exactly?
It actively changes how the kidney handles uric acid. So normally the kidney filters uric acid out, but then reabsorbs a large portion of it back into the blood.
Yeah.
Losartan inhibits that specific reabsorption transporter. It literally forces the kidney to dump the excess uric acid into the urine.
Wow. So if you have a patient with high blood pressure and gout, losartan is treating the hypertension while simultaneously clearing the uric acid that causes their joint pain.
It's brilliant.
You are solving two major clinical issues with one specific molecule. That's a masterpiece of a drug choice.
It really is. Utilizing a drug's secondary characteristics to your advantage is the absolute hallmark of an expert clinician.
Yeah.
And we see a similar critical distinction when looking at the diuretics themselves.
Oh, right, between the different types.
Yeah. For decades, the American Heart Association relied heavily on a diuretic called hydrochlorothiazide, or HCTZ.
But the new 2023 ESC guidelines strongly push doctors away from HCTZ. They heavily favor clothalidone or indapamide instead.
You know why?
Well, the notes indicate this shift comes down to half-life and hard clinical data. HCTZ is relatively short-acting, like it wears off.
Right.
But chlorthalidone stays active in the system significantly longer, providing this smooth, uninterrupted 24-hour blood pressure control.
Which is critical because a patient's blood pressure can spike dangerously during the night or early morning when shorter-acting drugs wear off.
Exactly. And more importantly, massive clinical trials comparing the two definitively prove that chlorthalidone results in better long-term cardiovascular outcomes. Like, it prevents more heart attacks and more strokes than HCTZ.
It is simply a statistically superior weapon. It's evidence-based optimization at its finest.
Okay, so let's follow this whole strategy to its logical extreme.
Let's do it.
You are the doctor. You've perfectly tailored the combination therapy. You navigated the gout. You avoided the ACE cough. And you match the patient to the right mechanisms.
Okay, feeling good about it.
You have them on step 2, triple therapy. They're taking an ACE inhibitor, a calcium channel blocker, and chlorthalidone. You have verified they are actually swallowing their pills every single day.
Always have to check that.
And you've run tests to ensure there isn't like a hidden tumor on their adrenal gland secretly driving the pressure up.
Ruled out secondary causes, right?
Yet despite maximum effort, the blood pressure refuses to drop. What then?
Well, that scenario removes you from standard treatment algorithms entirely. It pushes you into the dangerous territory of step 3, which is formally known as resistant hypertension.
Resistant. So the standard ABCD weapons have failed.
Exactly. The body's physiological defenses are actively overpowering your triple therapy.
Well, Dr. Sifula has a specific mnemonic for this exact crisis too, and it's Spiro saves pressure.
Yes.
Spiro stands for spironolactone. Why is this specific drug the ultimate backup plan?
To understand spironolactone, we have to look at why the body is resisting the first 3 drugs to begin with. In many cases of resistant hypertension, the patient's body is overproducing a hormone called aldosterone. And aldosterone's primary job is to instruct the kidneys to stubbornly hoard salt and water.
Okay, so even though you're giving the patient a diuretic to bail water out and an ACE inhibitor to turn down the RAAS system,
this flood of aldosterone is acting like a rogue override switch. It forces the pressure to remain high regardless.
So the body is essentially just fighting the medication.
Yes, but spironolactone is an aldosterone antagonist. It physically binds to the mineralocorticoid receptors in the kidney and blocks the aldosterone from attaching.
Oh, it cuts the rogue signal.
Exactly. The kidney finally stops hoarding the salt and water, and the resistance breaks. And this isn't just theoretical, by the way. It was proven in the landmark Pathway 2 clinical trial.
The Pathway 2 trial?
Yeah, the trial specifically tested different add-on drugs for resistant hypertension, and spironolactone emerged with the strongest, most rigorous evidence as the undisputed champion for that fourth-line add-on.
But medicine always requires a backup to the backup, right?
Oh, always.
Because spironolactone works by altering kidney excretion, so it carries a very high risk of causing hyperkalemia, that dangerous potassium spike we talked about earlier.
That's the catch.
So if a patient's potassium levels are already borderline, or they simply cannot tolerate spironolactone, the guidelines offer a plan C.
They do. Doctors can reach for entirely different classes of medication that operate outside the kidney and the RAS system altogether.
Like what?
Well, alpha blockers, like doxazocin, they target the nerve receptors directly on the blood vessels, forcing them to ignore signals from the sympathetic nervous system to constrict.
Oh, interesting.
Alternatively, central agents like clonidine bypass the blood vessels entirely. They cross directly into the brain and actively turn down the volume on the body's entire fight-or-flight sympathetic response, lowering the pressure right from the central command center.
The depth of this biological chess game is truly staggering. When we pull all of these guidelines and mechanisms together, a very clear picture emerges.
It does.
The four main classes, ACE inhibitors, ARBs, calcium channel blockers, and diuretics, are the equal first-line foundation, provided we reserve beta blockers strictly for compelling indications like heart failure or a previous heart attack.
Right. The foundational tools remain the same, but the deployment strategy has completely evolved to meet much stricter health targets.
Yeah, the modern ESC guidelines demand early combination therapy, throwing a synergistic 1-2 punch rather than relying on massive side effect heavy doses of a single pill.
Absolutely.
And if a patient hits the wall of resistant hypertension, spironolactone is the evidence-backed breaker of that resistance. But above all, I think this deep dive proves that the intricate microscopic details dictate the entire game.
The devil is in the details.
It really is. You never combine an ACE and an ARB because it destroys the potassium balance. Losartan acts as a secret weapon for gout patients by flushing out uric acid. And chlorthalidone definitively outperforms HCTZ by maintaining a 24-hour shield against pressure spikes.
The elegance of this system really just lies in mapping those chemical properties to the unique physiology of the human being sitting on the exam table.
Yeah. So the next time you see a blood pressure prescription, hopefully you recognize it isn't just a random guess. It is a highly customized chemical defense system built to outsmart a specific biological problem.
It's a remarkable achievement in precision medicine.
It is.
But, hidden within the dense text of these very guidelines is a profound tension that is worth thinking about as we wrap up.
What's that?
Well, we spent this entire time discussing the ESC 2023 push for a strict target of less than 130/80. However, the guidelines carve out a very deliberate exception for the frail and the elderly.
Oh, great.
For those patients, doctors are explicitly instructed to individualize the target, often intentionally leaving their blood pressure significantly higher, around 130 to 139.
Because if you push an 85-year-old's blood pressure down to that perfect lower target, they might not have enough pressure to supply their brain when they stand up. They get dizzy, they fall, and they fracture a hip, which is a catastrophic event at that age.
Right. The medications that mathematically fix the chart can physically devastate the patient, and it forces us to confront a really difficult reality about the future of medicine.
Yeah.
As our global population rapidly ages, and as our clinical guidelines demand increasingly aggressive early combination therapies to hit strict numerical goals, how will the doctors of tomorrow navigate that friction?
That's a great question.
At what point does the relentless pursuit of treating the numerical data actually interfere with treating the fragile reality of the human being?
From fixing the plumbing to treating the human,
Yeah.
it is a delicate balance. Think about that the next time you see those numbers flash on a blood pressure monitor. It is never just a number.